excited to be hosting this panel tonight. My name is Lisa, and I'm a first-year medical student and one of our events leads here at CUSPE. And we're excited to have you at this amazing venue, and hopefully our speakers give us a really interesting discussion, and we'd love for you guys to engage with that. Okay, so I'm going to introduce our speakers now, and we'll go into some introductory questions before I'll hand them over to you. Okay, so Mike. This is Professor Mike Kelly. He's a senior visiting fellow in the Department of Public Health and Primary Care at the Institute of Public Health at the University of Cambridge. Previously, he was the director of the Centre for Public Health at NICE, where he led the teams producing public health guidelines and communicating public health policy. You've been on the TV quite a lot, I understand. You advised the House of Commons Health Select Committee, and you've been a witness before parliamentary committees on a number of occasions, as well as chairing committees for the Food Standards Agency. Would you like to add anything to your introduction, or say hi to the group?
Yeah, thanks very much, Lisa. Yeah, no, that's about sums it up. And very pleased to be here this evening and looking forward to talking to you all.
Next up, this is Alison Thomson. Dr. Alison Thomson is a design-led researcher based in the Centre for Preventive Neurology at the Wolfson Institute of Public Health, which is part of Queen's Belfast University, based in London. You're currently a senior lecturer in patient public involvement and public engagement in science. So a lot of work in communicating science and trying to articulate how design-led methods can study the notion of patient experience and how we can transform that into practice. Your academic work is presented at a national and international level, and you also contribute to the practice-based design research community through establishing initiatives such as PhD by Design. Would you like to?
No, I think that was great. Thank you very much for inviting me. It's really nice to travel up to Cambridge. And yeah, I'm based at Queen Mary in East London. But I would love to go to Belfast as well. If anybody was based there, they would like to invite me.
And finally, Dr Shobhana Nagraj is an assistant professor of primary care and public health, and works in global health and on reducing health inequalities. You use implementation science theories and frameworks to help design and evaluate complex interventions that translate evidence into real-world practice. And the focus of your work recently has been in maternal and child health. Is that correct?
Yeah. Thanks, Lisa, and yeah, it's lovely to be here, and thank you for inviting me.
Okay, so hopefully we've given you guys a little bit of a flavour of who our speakers are tonight, and I thought we would open with a couple of questions on our theme of health inequalities. So, health inequalities exist at a global, a national and local scale and affect many different communities and populations. I'd love to start by asking each of you in turn to define what this theme of health inequalities means to you, and maybe where your work individually fits into solving this issue or approaching this problem. Mike, would you like to start us off?
Yes, of course. The simple thing about health inequalities is that the poorer you are, on average, the more likely you are to die young. Now, if we turn that into something that sounds a bit more scientific, there's essentially a gradient. And if you could imagine the association between, on the one hand, social standing or social status, and on the other, people's health, those in the higher social standing tend, on the whole, to have, on average, better health. And as you move down the social scale, health intends to become poorer. Now, it doesn't matter how you measure, and I was quite careful to say social standing, it doesn't matter how you measure that social dimension. You can measure it by education, you can measure it by income, you can measure it by occupation, and you can measure it by place of residence. It doesn't matter how you measure it, and neither does it matter how you measure health outcomes. It can be mortality, morbidity, even people filling in self-report questionnaires about whether their health is on average good, poor, fair, and so on. You still see that gradient. Now you see that gradient across all societies. There's no society where we've got data where a gradient doesn't exist. In developed societies, like the United Kingdom, United States, most of Western Europe and so on, the gradient is fairly smooth. You know, it runs like that. In developing or societies where economic development is not advanced, you get a more curvilinear type of gradient that is flatter for many, many more people, but gradient nonetheless. The gradients vary in their steepness. In societies that are more heterogeneous, like the United Kingdom and the United States, the gradient tends to be sharper. In societies that are more homogeneous, like much of Scandinavia, for example, the gradient tends to be less steep, but it's a gradient nonetheless. Now that's been a known empirical fact, if you like, since at least the middle of the 19th century, when William Farr, the sort of statistician in the forerunner of what was to become the Department of Health, began collecting data on housing and occupation and health. And by the middle of the 19th century, and certainly by the 1860s, this gradient and this effect of health inequalities was known and understood. So that's 1861. In 1861, the healthiest place to live in Great Britain was Surrey. And the most unhealthy places to live in Great Britain in 1861 were parts of Glasgow, parts of Manchester, parts of Liverpool, and parts of the East End of London. If we were to look at those data today, where's the healthiest place to live in Great Britain? It's still Surrey. And what's the health like in the East End of Glasgow, the East End of London? They're pretty much as poor as you can get relationally around the country. So, although we've known about health inequalities for nearly a century and a half or more, the ability of politicians, of governments, to really shift it, to change it, has been, at best, relatively ineffective. Now, of course, the overall health of the population for everyone has improved, and our infant mortality rates are better than they were in the middle of the 19th century. People live longer than they did in the middle of the 19th century. But the overall differences in that gradient remain and have been with us, as it were, almost one might say, in perpetuity. There was some interesting archaeological stuff done here in Cambridge a year or so ago. I picked up one of the papers arising from it, and it was about occupational groups in medieval Cambridge. And what the archaeologists have been able to do was determine how long the skeletons they found, I think it was in a graveyard up on Castle Hill, how old the skeletons were and what their social backgrounds were. And believe it or not, in medieval Cambridge, there was a gradient in health that you can spot in the archaeological evidence. Now, as Lisa said in the introduction, I was the Director of Public Health at NICE for 10 years. And in that time, we produced a number of public health guides, about 50 public health guidelines, which address various elements of public health interventions that are workable and cost-effective. But in the statutory instrument that gave NICE the responsibility for public health, which it didn't have when it was originally established, it only took it on in around 2005. In that statutory instrument, it says that in NICE's public health guidelines, it will examine the extent to which the public health interventions, which are known to be effective and cost-effective, what impact they have on health inequalities. So in that entire 10-year period, we had the task of trying to work out what if you put in a program about, say, smoking cessation, or alcohol misuse reduction, or improving maternity outcomes for women likely to have low birth weight babies, all that kind of stuff. And in each of them, we would try to find out what would happen in terms of the health inequalities gradient as a consequence of the interventions. And I think there are two things that I'll draw out from that. There's many, many things that one could draw out, but two things are particularly striking. The first is, if you try to apply the principle a la Michael Marmor of proportionate universalism, in other words, you try to try to create guidelines or interventions which are differentially designed for different parts of the population, you immediately run into a problem. And the problem is we don't know enough about the effects of interventions in different parts of the population to be able to forensically design interventions so that they will be differentially effective and in terms of proportionate universalism to help those most in need. Those most in need benefit most. The second thing to say is that even the most effective interventions sometimes have the unintended effect of making health inequalities worse. Because what actually happens is that the take-up and the receptiveness to the interventions tends to be greater in those who are already in the most advantaged circumstances. And the pushback and resistance to interventions tends to be much greater in the areas where there are greater needs. We simply haven't got the architecture in place yet, or the research data in place yet, to understand the granularity of populations in such a way that it's possible to do that rebalancing of the gradient so that it levels out in a more equitable kind of way. So for 10 years, I struggled with that problem, never solved it. I always blamed the scientists who were collecting the data in the first place, because while they do collect data, of course, about age and occupation and social differences, mostly that data are used to test for confounding in the evidence rather than to test for differential effectiveness in different parts of the population. And that remains a major problem when you're put in a position like NICE are of trying to develop guidelines that will have that kind of equitable sort of effect. So in terms of what it means, we know we've got a problem. We know that we've seen relatively little by way of improvement in these things. During the period of the Blair-Brown years, I think it's important to say that gradient did level off a bit, but it immediately sharpened and became steep again the moment austerity kicked in. Not really very surprising, and anyone who knew anything about health inequalities would have been able to predict that from, as it were, day one. But even then, it was a relatively slight shift, a beneficial one in terms of levelling the gradient, but not decisive enough to continue on as governments change. We know we've got a problem. How to deal with that problem has eluded politicians, governments, policymakers, and scientists really, and we've still got much to do.
Thank you, that was a really great introduction to our topic. Now, Shobhana, I understand that your work is more of a global focus, and especially the reason that you came into health inequalities is through travelling abroad and seeing disparity and gradients in health, not just within countries, but between countries. Could you maybe use some of your experiences to expand on maybe how you perceive health inequalities at more of a global level and why it's important, the work that you do?
Thank you. I think that the same challenges face countries all over the world, and also the UK. I see exactly the same inequalities here. I work in Luton, and there are exactly the same challenges that we face here as well as in other areas overseas. One of the key focuses of reducing health inequalities on a global scale is a focus on universal health coverage. And in the UK, we're very lucky that we have the NHS, but even with the universal health coverage, there are aspects which reduce the access to health services, financial protection, and the quality of care received, which are the three components. So when we're thinking about reducing health inequalities on a global level, is actually how do we improve health services and health systems and design our interventions and health system policies that we ensure access for healthcare to all, but also thinking about how do people get to health services, but also what health services are available when they actually reach them, and what the quality of care is that they'll receive there. So we have to act on all those levels, so at a macro level, at a health system level, to ensure that we have equitable access, that actually the services are there for people, but also actually how do people identify that they've got an illness. So even if a health service is there, for example, I work with pregnant women in very rural areas, they might not have any education at all, not know when to contact a doctor. the same problem as here in the UK of access, and those are some of the structural inequalities that we need to address, which are systemic and avoidable, and some of those are to do with inequalities in terms of our interactions with people, the way that we deliver healthcare in an empathic way, and also structural barriers such as language, culture, and other areas as well. So I hope that sort of answers a bit of the questions.
Yeah, no, that's great, thank you. Yeah, I wanted to ask kind of about the balance between global health inequality and kind of public health on a more national scale. How do we, or do you think that our developed countries such as the UK should be doing more for global health inequalities and helping those less fortunate countries? Or do you think that as we focus on our own health systems, we can develop technologies that can then be translated into other areas?
Thank you. So I don't like to use the term developed and underdeveloped countries. I think that we are global citizens. I think the world, if we look at it as a whole, there's a word in Southern Africa which is called Ubuntu. I don't know if anyone's heard of that word, but it's I am because we are, and it's this collective feeling that actually we have a social and moral duty to look after each other. As I mentioned, the same issues that I see in rural India exist here in the UK as well. And so economic or financial protection is one element of universal health coverage, and economies that are flourishing are able to look after their populations sometimes because they have those access to resources. So I think that there's a lot we can do in terms of changing our thinking about how we do that as well.
Definitely. You have a very empathetic outlook that I'll definitely try to kind of ingrain in myself as well. Now, Alison, Shobhana's talked a lot about access to healthcare and how do we engage people in healthcare, and your work has focused a little bit on engaging the public in science and in health. Could you talk to us a little bit about the importance of that and about the challenges that you face?
Yeah. So for the past maybe 13 years, I've worked with multiple sclerosis researchers, and I always like to start with my story that when I first met them, I said, "What do you research?" And they said, "Multiple sclerosis." And I said, "What's that?" And they said, "It's a disease of the central nervous system, blah, 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 blah." And at that point, I didn't actually know what my central nervous system was. And I'm really proud of that, because that just shows that you can be a well-educated, white, middle-class person and not know what your central nervous system is. And unless you have a keen interest in science and biology and health, then that is potentially the general public's understanding of biology and health. And I was talking to those MS researchers, and they didn't realise that maybe a lot of their patients also didn't understand what a central nervous system was. So beyond not knowing that, how do their patients then understand everything else they're talking to them? And so that's where I started working with them around breaking down the assumptions of what they thought their patients knew, and then that flipped how they then spoke to their patients in clinic, starting from where they're at, rather than where them as healthcare professionals were at and what they wanted to tell them. And so we've used lots of different methods. Most of them are not verbal, most of them are physical, using objects, tools, imagery, music, knitting, different ways to communicate and connect people together, which doesn't have that assumption that you have this level of scientific knowledge before you can then understand what's happening to your body. So that's how I came to science communication, engagement, and that links to health inequalities, because I think there's so many assumptions, the starting point about somebody's life, about what's important to them, about what they already might know or not know. And I think when I work with a lot of, I do a lot of work with participatory researchers, and they are really good at breaking down the assumptions of first what knowledge is, and then how that then leads and drives research. So for example, in that project, they were, the idea and the concept, which is has a lot of traction at the moment, of gaslighting. So people with MS specifically what we've found from specific ethnic backgrounds or from specific areas of the country that they live, when they are talking about what their symptom is, they don't have the language of fatigue, because sometimes fatigue doesn't exist in Urdu, for example. That word, that concept just doesn't exist. So then what the stories that they're telling about what they're feeling are they're not believed and they're not heard, which means then those symptoms aren't recorded, they're not actioned on, they are then not referred from the GP to the neurology service, they then don't see an MS neurologist, they don't go on to treatment, their MS gets worse, etc. And then it just cascades. And that isn't something that's rare, that's something that what we found happens a lot. So it's problems around what evidence is when it comes to health inequalities, when it comes to patient experience, and then how that's acted upon. So that's one aspect of it, but I thought what was quite interesting is that you're both talking about designing interventions, and that is an intentional activity which has and brings together a lot of different types of evidence. But I always like to ask, when those interventions are designed, was there any designers in the room? Because that in itself has a different form of evidence that brings in and works across all of the other objective, subjective, rigorously applied and developed types of evidence. And so I think it's really interesting when we move towards tackling health inequalities, and I work at a very small scale, how we bring in different skill sets and expertise to bring these different types of evidence which have different agencies in different spaces, and how we act upon them to connect humans to then do something with that or engage in a different way.
Thank you. I wanted to kind of follow up on some of the things that you've said. So you talked a lot about different interventions that you've tried in the past and how things like activities such as knitting can help people to kind of understand their health and communicate and kind of form part of a community and feel listened to in their health. I wanted to know, have you had any struggles in kind of implementing those interventions? So once you've designed an intervention and you've figured out that it works, what are your biggest roadblocks in making sure that people then have access to these kinds of interventions? And is that something that you, as part of your role?
Yeah, I mean, even that language of implementing an intervention has a lot of assumptions within it, that that there's a kind of a world out there that needs to be implemented on, and it's not changing and contributing to the problem or changing the intervention, and that the intervention is very clean and tidied up over here. Not to make it complicated. And I think, I think within health, moving from health research to kind of delivery and applying something, it's very much this kind of mess, in that things do go wrong, and in research practices and in the way that we develop different projects, we very much lean into that. And so the problem's not going to be solved once an intervention is applied or delivered and measured and proven that it works. So one example is from clinical observations was that our MS team had nothing to support families who were affected by MS. So if an adult was diagnosed, turn around to their child and talk about what the MS diagnosis might mean. And with this kind of storm of prevention coming along, so the children would have to be ready for potentially a preventative intervention to come along in maybe 10, 15, 20 years time, depending on who you talk to. So the problem was a very kind of, well, we could do this and change this and communicate this, so then this population of future patients are ready to be implemented on. But actually, that's not a problem for lots of different people, because they're dealing with their MS right now, or they're dealing with the anxiety of even mentioning that to their child. And then when we look at it from the child's perspective, they actually didn't care about their parents' MS at all, because they wanted to get to football, or they wanted to do something else. And so when we shifted the problem, it actually would then change the intervention completely. And so when we tackle problems like that, we do it from a human-centred perspective. So where you have the evidence of the science, or the evidence of the need from the clinic, or the evidence from the nurses, but actually we were then led by what was important to the child, what was important to the parent, and those can be quite conflicting and quite challenging. So it's not a very helpful answer if you want a clean solution, but it's more a way of thinking about what you think you're doing when you're intervening.
No, I think that was really interesting, especially how we can bring in and listen to more of the people that we're trying to, not intervene on, but the people that we're trying to help with our work. And I was thinking from an international perspective, Shobhana, a lot of the work that you do is based here in Oxford and Cambridge, and maybe some things work in the UK, but you might travel abroad, and obviously people's experiences are different, people's problems are different. How do you go about making sure that the communities in need of help in their healthcare, and the communities that you're trying to work for are really included in the discussion and the design of your interventions or what you're trying to?
Thanks, Lisa. So I think building trust and actually living in communities is really important, so you actually know what their actual priorities are and their needs are. I can give an example of some work that we did in rural India in two very diverse states. In Haryana in the north, it was what we call the brick factory place. So if you go on the roads, they're lined with these massive brick towers, and has a large migrant population of women who would live hand to mouth, so they literally just earn enough for that day to keep alive. And so they would work until the day of delivery because they had no idea, no way of sustaining themselves otherwise. And the other state that I was working in is in Andhra, which is in the south of India, and that's the red chili capital of India. So when you go in the summer, the air is really full of spices. And when we're working with those communities, we'd gone with the presumption that actually cardiovascular disease or heart disease is the leading cause of death in women, and two big risk factors for heart disease are diabetes and high blood pressure. And in India, for some reason, the population gets those illnesses a decade earlier than in other populations. So I'd gone in with this project thinking, oh, if we target women in pregnancy around their blood pressure and diabetes, and then we get them into follow-up, but then we can reduce heart disease in women. And when I got to the communities, their problems weren't at all related to diabetes or high blood pressure. They were concerned about how much food they had to eat. They had hemoglobins of 3, which is extremely low, and in this country would be incompatible with life, we'd think. But actually, I've seen that play out. They didn't have enough food to eat, and actually the main problem was anemia. And so doing that in-depth contextual work with the communities, finding out what their needs were, was really important, because we completely redesigned the intervention and redesigned the programme of work. We included the diabetes and high blood pressure because that was what was needed at a policy level, and that was what the government needed, but we married that with a community approach. And Alison mentioned this, but we used human-centred design, worked with designers as well to design an intervention. And actually, in the end, it was tested and shown to reduce the anemia in population. So I think building that trust, incorporating people's views into the design of interventions, making sure that you know what their priorities are, and really good stakeholder engagement, so involving policymakers and communities and healthcare professionals in the design is also extremely important, and also for sustainability after you've done the work as well.
Do you think we use a human-centred approach enough in our research, in the UK especially, or is this something that we really need to work towards?
I think we definitely need to work towards it. So I think a lot of things are done to people because they seem like a good idea. I know Susan Mickey, who's a behavioural scientist at UCL, she says something called Islagiat theory, which is, it seemed like a good idea at the time. So a lot of what we do seems like a good idea at the time, but actually when we get to the ground and find out what the needs are, it's not often what people will want to do in their lives. So human-centred design does work on a systems level. It incorporates empathy, so you can embed empathy into the design of the intervention. and it's also iterative, so you can keep refining the intervention, and it looks at those root causes, so it looks at the underlying problems in society, so the social determinants as well.
Amazing, thank you. Okay, one last question before I'll pass you guys on to the audience. So Mike, please add to this discussion if you had anything to say, and I also wanted to just add another question of sometimes we do get things wrong, and how do you go about communicating to the public when you have made a mistake in policy or in research or in an intervention that maybe hasn't played out how you expected it to? How do we rebuild trust in healthcare and in the system?
Goodness. I think the answer to that question, short answer to that question, is with great difficulty. And difficulty because sometimes, you know, political systems, political people, politicians, and indeed policymakers are wedded to particular ways of doing things, either because they believe that that's the best way to do it, or more usually, perhaps habitually, there's a kind of, and as you sit, as I often did, in the Department of Health, you know, each of the teams in different aspects and areas have ways of thinking and working which are highly recursive, they repeat themselves. And so getting system change and even system thinking change is quite tricky. So I don't think there's an easy answer to that. Can I think off the top of my head of interventions that were utterly wrong and disastrous? I'll give, the example I'll use is behaviour change. Because so often the default position is that, okay, what are our problems? Cardiovascular disease, yeah, it's about people's diet, it's smoking, it's lack of exercise, and you see it. I saw it in every Secretary of State that I had contact with in those years. There's a kind of light bulb, like, right, what we do is behaviour change. We can get people to stop smoking, we can get people to take more exercise, get change their diet. And then the problem that really kicks in, because rather than looking to the evidence about how to do effective behaviour change, you mentioned Susan McGinn, her work is probably as good an example of the best we know about doing it. But that's not the behaviour change which government does. I mean, what was it the Secretary of State said during COVID? Let's scare the pants off people. I believe that's what Matt Hancock thought was a good way of getting people to comply with directives on mask wearing, social distance and so on. In other words, there's a default to the simple solution, which is let's get the message right, let's get the message louder, let's get the message more consistent, let's employ advertising agencies to help us do the messaging. And actually, years and years and years of efforts at behaviour change, which have been dominant in public health policy, show very little return in terms of actual behaviour change. It's more complex than just getting the messages right. I think one of my most quoted papers is, the title is, "Why is changing health-related behaviour so difficult?" And the first sentence is, because policymakers, practitioners and academics make it difficult. And that's because they do the wrong stuff, essentially. Now, all the things you were talking about there, Shobhi and Alison, in respect of working with communities, that's been around a long time in public health. And efforts to do it and do it better are really kind of, they're ongoing. But there are one example that comes to mind of when it was done very, very effectively. My early part of my career, when HIV was kind of getting going. And at the time, it was far from clear what was going on, what the nature of the disease was, and how it was going to play out. And, you know, the Chief Medical Officer at the time, and the then Secretary of State, Norman Fowler, looked at the data from the United States and were basically terrified. They wanted to do something. Now, in terms of what happened in respect of that, I think we didn't know what to do. There was no drugs available, there was no cure, and in turn, well, we could do messaging, and there was messaging. But I think one of the more effective dimensions came when members of the public health profession realised that they needed to work with the communities who were in various degrees at risk. And there was a lot of community-led type stuff, both with the gay community and with intravenous drug users. And coming out of that were things like the availability of condoms in social venues. And with respect to the drug users, this was really something that worried a lot of politicians and police officers, was the idea, well, why don't we make clean needles and syringes and other drug paraphernalia available to intravenous drug users, so that they're not sharing needles and therefore passing on infection in that fashion. And in some jurisdictions, some parts of it, they did that. Did it very effectively in Glasgow. They didn't do it in Edinburgh because the local constabulary didn't want it done, and the result was the epidemic did go in the kind of Californian sort of direction. Now, they were examples where, you know, that didn't come from research particularly, but it came from listening to the communities who had something to say about what would help them. And so I wouldn't want to give you the impression that it's all, public health is all about doing stuff to people. Some of it is, but not all of it. And when it works best, it's when it comes, in the old phrase, bottom up, as it were, working with communities in finding out the best way to do stuff. And we don't do that often enough. And it's certainly, although modern day research, we have patient and public involvement, you have to do those impact statements when you put your grant into the MRC or NIHR. But doing it meaningfully is much more difficult than writing an impact statement and that sort of thing. So we do need to do more, no doubt about it. Just one other thing, NICE didn't design interventions. What NICE did was find out which interventions had the best evidence to support the fact that they were working, and then work with patients always, end users always, of whatever interventions were being looked at. So did we involve design? No, because actually, and here Susan Mickey's absolutely right, it seemed like a good idea at the time. There's an anecdote. So politicians sometimes come up with really interesting ideas. And one really interesting idea that came along during the Blair years was fruit for schools. So the theory, well, what do we do? Children's diets need to be improved. What would be a nice way to do it? Well, we could put fruit into schools, in primary schools. Yeah, and that was dreamt up in the back of a minister's car on the way to another event. Anyway, of course, the problem with that, not the theory about the importance of child nutrition, that's spot on. But what happens if you deliver several crates of oranges and bananas to a primary school that hasn't got a kitchen, that doesn't have any storage space, and doesn't have any means to distinguish, because there was a very specific age grade of kids who were able to have the stuff and those that weren't. If you don't give teachers the resource to actually cut, you can't let the kids have the knives to cut the oranges up. I mean, 4-year-olds and a sharp knife would be really pretty bad idea. So in other words, the problem wasn't the idea so much as how you would then implement it across the system. Because unfortunately what would happen in many primary schools, come Friday afternoon, well, that's all going to go rotten by Monday, so we'll just give it to the kids in the playground. And those same oranges and bananas became fantastic missiles for the children to throw across the playground at one. Great fun, no doubt, but whether the nutritional value of the oranges and the bananas was got from being hit on the face by an orange is very much in doubt. One other example, and it's the same minister actually, and this is a problem that if you're working at the interface with policy, even if your evidence is the best you've got, even if you're absolutely sure it's the right thing to do, you can't be sure that the minister's going to go your way. So, I was on a panel, a bit like this one day, an audience there, and sitting where Shobhi is was the minister. And on the 2 weeks previously, the civil servants had been, before I worked at NICE, I worked at the Health Development Agency, the civil servant's been on the phone saying that, Mike, the minister's making a speech at the event you're at in a couple of weeks' time. Can you give me all the evidence you've got to support what she's going to say? Well, that's not really the way science works, but you know, that's what you have to do. And it seemed about right. So we prepared an evidence brief for the minister. And as I sat there, someone was giving a talk, I was looking at the minister, and she had on her lap the speech, which was based on the evidence that we provided. She had a blue pencil. She was going through it, crossing it out, and she was writing other stuff in. So the speech she gave bore a very limited resemblance to the evidence that we'd supplied, and it was all seemed like a good idea at the time. And although the anecdote is actually true, and that minister is now a minister once again, and I'll leave you to work out who it might be. And a very good minister, as it happens, and she was good as a junior Minister of Health. But at the same time, that process of the politics overtaking the evidence and the way that real-world government actually works is quite some distance, you know, from our carefully worked out p-values and all the rest of these things that we spend our time worrying about. Not sure I answered the question, but it was an interesting anecdote anyway.
Definitely some really useful insights. Okay, so I'm going to pass to the audience for some questions, but just to summarise our discussion so far, it seems like the really important takeaways are to kind of marry that work with communicators, work with communities, work with designers, and also to work with researchers and to kind of bring that all together. And it seems that work needs to be done in the way that we design research, the way that we implement it and evaluate it as we're trying to roll out our interventions or our solutions that we've come up with, and also the way that we communicate research to the public. So thank you guys for discussing with me, and I'll now pass to the audience for some questions, if anybody has any. Yes, you in the stripy shirt.
So I just wondered if you can you hear me? I don't know if I need a microphone. Anyway, thanks, Mike, for the mic. So a lot of experts see the shift towards preventative medicine and the promise of whole genome sequencing, and once we can interpret all of that as a way to equalize or flatten out the curve that Mike spoke of earlier. So just wondering if each of you could respond if you do see that as a game changer. And then you did talk about the vicious cycle about how lifestyle choices really do impact health outcomes. So then in relation to that, will preventative medicine make a difference on those communities where we see lifestyle choices continuing to kind of keep them in that lower part of the curve? Thank you.
Thank you for the question. So I think, so the first bit about genomics, I think it does have a role, but there are the social determinants of health that we've been speaking about, which are independent and interact with those things. So there is the concept of epigenetics as well, that these actually have an influence in terms of outcomes as well. In terms of actually resources and how we use those, if we make sure that people have affordable and good housing, access to clean water and sanitation, access to good healthcare and quality of care, those basic needs, once they're met, can actually improve health outcomes and have an impact in terms of cost savings to the NHS and other health systems globally. And so I guess my answer to that would be that I don't think whole genomic sequencing will solve the problem of health inequalities. I think that the social determinants will always be there, and that we need to address some of those as well.
Yeah, I agree. The hype surrounding much of this is hype, and is not going to give us the answers within decades. Presently, looking at someone's birth postcode is a much better predictor of their health outcome across the life course than anything we've got available through genomics. However, what I would say, and Shobhi mentioned, epigenetics, I think, is a really interesting arena, because what we're seeing essentially from the earliest epigenetic studies, the work of David Barker, the Dutch famine studies, all that kind of stuff, is speaking very loudly to the idea that there's a social and a biological inheritance that are interacting with one another. And I suppose I would be arguing, not where I would like to see the research developing, is in the mechanisms linking the social and the biological, and understanding those much better than we do. Presently, almost all of the data are associational or correlational, rather than mechanistic in understanding the nature of what actually is it about poverty that kills you. Because it's easy to say, and you can see the data, but then understanding the nature of the way people's lives interact with both their social circumstances and their human biology is something that is presently is much less well developed than many other arenas we work in. And I suspect if you're looking to find predictive stuff, that's where it's going to come, rather than some of the hype that you hear talked about with respect to that development. So I'm not knocking it, because it's good science, but it's not the answer to the public health problem that we're dealing with here.
I just want to add one more thing, which is about what Mike just said about poverty, because I think a lot of it is about agency. So poverty reduces human agency in a way that other factors that we look at in medical research, we can't sort of compare that. So if somebody's in poverty, they don't have the agency to make the same choices as other people who don't have more affluent circumstances.
Yeah, definitely. I was actually going to bring that up. One of my lecturers on the medicine course, he actually refuses to call things behavioural choices or behavioural factors because of that aspect of choice. And I have one friend especially, so this professor works in obesity, and I also have a friend who is a food activist, and he talked to me once about the fact that in the area of Leicester where he comes from, his region is kind of, they have almost a lifespan of maybe 5 years shorter than more affluent parts, and a lot of that is to do with the fact that money gives you the freedom to make better food choices or healthier food choices, and also the time to be able to cook for yourself. So I thought that was a really important point, and a lot of the interventions might have to be more governmental and on that economic and poverty side as well, and kind of marrying work in health and work in the economy. So one example of what my friend did is he managed to campaign the government to ban, I think it was junk food ads before 9 PM, so that children would not be confronted as much with those kind of unhealthier options, and they would have more of that agency to be able to make better choices for themselves.
Yeah, I think the idea of prevention is really interesting because it's a speculation, and there are fields of sociological research and design-led research that deal with speculation as a material, because speculation is subjective, and then there's the obvious inequality of who's doing the speculation. One word that we've not used is power, and agency is, I think, probably, it's a form of power. So, in research, we've started to kind of open ourselves up to the idea of, participation, PPIE, for example, and that ideal. But really, when it comes to preventative medicine, there has to be, people have to participate in that. And we're not good at doing that now. So hopefully we can get better at doing that in the future, but that means giving up power. And so I think the question is, are those with power open to speculating in a way which is more equitable? And I don't think that medical research and other areas are very good at doing that, or see that as a way that they can actually change futures of people, which they do make tangible. It's just mine.
There's a question there. So.
Yeah, we'll take your question first.
My name is Faber Peters. I'm on the MPhil in Population Health course, and I was only at your lecture yesterday on health policy. So this session is to Shobi and of course Mike. First of all, in low and middle income countries, I'm from Ghana, where there are such perpetuity in healthcare inequalities, which is compounded by, of course, fragile health systems, limited data, and even under-resourced primary health care. How can implementation side, like you both mentioned, be leveraged to ensure that the interventions that are raised are actually aimed at reducing these health inequalities at these places? And they're not only evidence-based, but they're also locally led. You mentioned cultural, structural barriers, as well as language and religion. How can we incorporate all of these things into making sure that the interventions are not just for one specific population, but they can be also replicated across different places and different populations? And question number 2, this is to Mike. While much attention is paid to patient voice and lived experiences for countries like the UK, the US, and the developed West, how can global health actors like myself or my classmates ensure that communities, of course, in the global South, who often lack formal platforms for civic engagement and not engaged in policy making, how can they equally also be empowered to shape healthcare interventions that affect them, so that they're not also sidelined or marginalized?
Amazing questions, thank you.
Thanks so much for that question. So I think when we're designing interventions, we've talked a bit about the design and how we involve communities in that. One of the ways that we can make things that are hyper-local more scalable and to think about what's actually happening is to actually think about either a program theory or a theory of change. So we actually think about the elements of what we're doing. So so for example, Mike gave the example of putting fruit in schools. What is that actually doing? So we break down that intervention into different components and think about the different pathways that has to the impact that we want to achieve. And we can use, through lots of research that's been done in the past, theories which are based on empirical research to actually think about what's happening during that time. How do we improve human agency in our intervention design? How do we actually incorporate empathy and embed that into the design as well? And to think about actually the mechanism. So a lot of people now, in the last sort of Medical Research Council's complex intervention guidance, is around realist approaches. So we think about actually what context we're working in, what the outcomes that we're interested in, what those mechanisms. And so we think about interventions in a way that we have those replicable elements that we can take, and to think about how it's working. So it's that black box between intervention and outcome, what's happening in that space, and can we understand that better? And the only way we can understand that is by actually working with the populations and actually understanding how they interact. And these things change over time, so often I think about theories of change and how we design them. They're living because we reiterate them, because policies change, people change, circumstances change, there's pandemics, and then we need to change our interventions as well to be flexible. But if we know what's in that black box, that becomes easier.
Yeah, it was a difficult question as well, wasn't it? But I don't have an answer. But what I would say is that the starting point should be, what do we actually know already about the societies of interest? Not to assume that we know already what the problem is. And I think a lot of, this is true home-based research in the UK as it is for other societies, the assumption is made that we know what's going on in these communities, we know what the problem is, and we therefore know how to solve it. And I think that is absolutely the wrong way round. But that doesn't mean we don't know anything, we know nothing. So what information is already there is the starting point. And then all of the things that Shobhi said just now in respect of working from the ground up with those communities, and then designing whatever it is you're going to do on the basis of what emerges, and within a realist frame of reference, as she said, is as good as we've got at the moment in terms of trying to do it better. And I think that's about as close as I can get to helping, but not to assume we already know the answer, and not to assume that we know nothing. What's the middle ground then about what is known and what can be done, and then the realist frame can come into play necessarily more effectively than if we just go in thinking we know what the answer is.
Amazing, thank you. We have some questions in the front. Would you like to start us off?
I'm going to say this is going to be the last question for drinks, but then you can pester them after that as well.
I'm Catherine Mead, I'm Professor of Health at Anglia Ruskin University. Now, I wanted to go back to the notions around power, because it recently come to my attention around the extreme right-wing agenda that's going on at the moment. In the States, the equality, diversity and inclusion initiatives have all been abandoned. It seems to stem back from something called the 1776 report, which takes the statement by President Lincoln that all men are created equally and justifies that as no person should be treated any more better than anybody else. And that somehow is then translated into we can't actually promote different groups in society who need help, because that's contravening what President Lincoln said about all people are made equally, so should be treated equally, but obviously they're not. But there's a very extensive right-wing think tank called the Heritage Foundation that is organising meetings in Europe around very right-wing ideas. So this is white supremacist, anti-EDI, anti-LGBT, anti-women, anti-abortion, anti-contraception, all sorts of other things. And you can see how their ideas are being picked up by various political groups. So, for example, Reform UK seems to have taken quite a lot of their agenda from the Heritage Foundation website and Project 2025. So we're going to need an awful lot more justification about why people are doing stuff around health inequalities at all, let alone going into the more finer details about how to do it. Because if we're not careful, the whole lot will be wiped out by a political agenda that says this is not necessary, it's not helping, it's not doing anybody any favours, and it's morally wrong. So I don't want to see that happening here, but it's already happening in the States. You know, some of my collaborators are losing their jobs, and data sets are being deleted, and other rather worrying things are happening over there. So what riposte do you have to this agenda that seems to be sweeping around Europe and in the UK?
Well, first of all, Catherine, I agree. I mean, it's some very alarming events going on globally, but particularly in the United States presently. Now, a couple of observations. The first is that public health is always political, actually. You can't be involved in public health. Even your minor stuff one might think of about more exercise or smoking bans, this kind of stuff. You know, whatever it is you're doing, if you're doing it in public health, it's political. And that is a reality that was true when the healthcare reformers of the 19th century started thinking about towns and cities and sewage and clean water. The battles that were had in London to prevent the building of Sir Joseph Bazalgette's clean water system and sewage system went on for nearly 25 years. So, you know, it's never easy. And I did say to the students yesterday that were mentioned a moment ago, if you're looking for a quiet life, don't go into public health, because you ain't going to get one. Secondly, it's about, as you rightly say, Catherine, it's about power. And power is a dynamic that has an impact, clearly, on people's health, both generally and more specifically in the cases of the examples you gave of the Heritage Foundation and the rest of it. I think the second big observation is that our public health systems are always fragile. You know, the moment you see either a climatic event, a geological event, an earthquake or a volcano, it's not very long before you see the public health systems that we take for granted so often begin to fall apart, and waterborne disease rears its head, you know, within days as a rule. But it's not just those physical infrastructures that are fragile, it's the nature of the kind of agreement we have, the settlement, if you like, which says the state will do certain things to look after its population, which we have agreed, tacitly perhaps, that they will do on our behalf, without which we're in very serious problems in terms of disease, incidence, prevalence, and all the things that we know about. And so all of us, it is important that anybody, all of us who are working in public health, keep in mind the fragility of what we're working with, even here in the United Kingdom, as well as what these very real political forces that are arrayed against public health and many other aspects of other taken for granted systems that are here, as we work in it. So I don't have an answer, but I do know that we need to be very, very careful, because otherwise these things can creep in a way that would be entirely harmful.
My answer was really about using the language that they're using, so adding on to everything that's already been said as well. There's no easy answers, but if they are using constitutional language to justify those actions, then we have access to language which is universal. So if we speak of universal health services and use the terms of access